So the MA.17R trial was basically designed to look at continuing aromatase inhibitor in the adjuvant setting past 5 years. So it was kind of a follow-up to the MA.17 study where patients who'd had 5 years of tamoxifen got letrozole or not. What they were planning to do was re-randomize the patients who got letrozole in that study to receive another 5 years of letrozole, so a total of 10 years versus a placebo, so compared to 5 years of letrozole. In the trial, about 70% of patients had prior tamoxifen, about 30% just had prior aromatase inhibitor therapy. So what it showed was it met its endpoint. There was a decreased recurrence rate, which was significant in the patients who had 10 years of letrozole compared to the 5 years. However, there were a few caveats with the trial. One being that the disease-free survival they looked at did not include deaths from other causes, and actually when you put that in, there wasn't a significant difference between the two arms. They also had to change the analysis because they didn't have enough events actually that they planned previously. And the other big thing is a lot of the difference was in the incidence of contralateral breast cancers. So the contralateral breast cancers were decreased by almost 60% in the patients who got letrozole versus those that got placebo, versus the distant event rate, which was really very low, I think. So I think the implications are that, it shows that in certain patients it's safe to continue aromatase inhibitors through 10 years, and it does appear to have some efficacy. I think most of us were kind of continuing aromatase inhibitors beyond 5 years in patients who were high risk, for example, patients who had a lot of positive lymph nodes. I think this supports that type of an approach, but I don't think it was really that practice changing in terms of what we do taking care of patients. The NSABP trial, which was basically designed to compare 10 years of an aromatase inhibitor versus 5 years. In fact, those patients either could have had 5 years of an aromatase inhibitor or tamoxifen for 3 years, followed by an aromatase inhibitor for 5 years, and then they were randomized to another 5 years of an aromatase inhibitor versus not. That hasn't reported out yet. It's a larger trial, so I think that may give us a little bit more data in terms of how to manage these patients. I think the problem is that we just don't know which patients require this longer therapy. And there is some cost to it because the patients who continued the letrozole through 10 years actually had a higher rate of fractures compared to the patients that stopped, and also had a higher rate of new onset osteoporosis, despite the fact that almost 50% of them were taking bisphosphonates. So there is some cost to this, and I think it's also, it was somewhat selective patients because they'd already got through 5 years in aromatase inhibitor. A lot of patients really struggle with that. So I think, it's certainly very reasonable for some patients, but I think having some kind of molecular marker to tell us which patients need the extended adjuvant therapy, I think would be very useful going forward.